Welcome, everyone, to our final session of the Oxygen Therapy and Critical Care case-based series. Today, we're going to be talking about frequently asked questions, everything that you have asked as our participants up through the last 11 sessions. So with us, leading us today is Dr. Anna Maria Crawford, as usual. And with her, we're honored to have Dr. Freddie, Dr. Lisa, Dr. Rediot, Dr. Santiago, Dr. Bryant, Dr. Fred, Dr. Jean-Claude, and Dr. Al-Hassan Dati. Just a couple ECHO etiquette and housekeeping reminders. Our programming is based on a foundation of love and respect, so please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for questions and answers, which is at the bottom of your screen. Please send all questions through the chat box and feel free to introduce yourself there. Please turn on your video, position your webcam effectively to show your face if you're alone, or to capture the whole group if you're with people. If you have any IT issues, send a message through the chat. This session is being recorded, so your attendance is recorded. Thank you. Please be mindful of infection prevention and control, and try to limit the number of people joining from one gathering place and practice physical distancing. Interpretation is available for this session. If you would like interpretation, at the bottom of your screen, there are different options. We have French and Spanish available. You will need a new version of Zoom for this to work, but you can choose to mute the English part of the session or listen to both. The translation will be louder than the original speaker. Now over to Dr. Anna Maria.
Hello, everyone. Welcome. We are very excited to see you again. And very, very excited to have such an amazing group of panelists. As you know, we have had several sessions, and this is the final. This is the 12th session of 12. And we have compiled all of the questions that you sent in, so the frequently asked questions. And we're going to go through those today and also share with you some very high yield resources that you can use when taking care of your patients. So I'm going to go ahead and start screen sharing, which will share the Learning Resource Center. The link to the Learning Resource Center is in the chat box if you'd like to follow along. I would also recommend that you make note of the link so that after the session you can access the resources. So again, everything is online available to you. The Learning Resource Center works both on the computer and on your phone, both Android and Apple's phones. So we welcome you. Grateful to all of my panelists today. Some really great friends and colleagues have joined me to help answer your questions. So when you emailed us all of the questions through our surveys, we've decided to divide them up into 5 different categories. Since this is the Oxygen Therapy and Critical Care webinar series, we have a section on oxygen therapy, another one on critical care. Additionally, we have some COVID-19 specific questions, and then a couple questions coming from obstetrics and pediatrics. There were additional questions, however, they were outside the scope of these sessions. So we would just encourage our participants to explore some of the resources that we have listed for you, and you can find the answers to all the questions that were sent in. So with that, we're going to start with oxygen therapy. And our first question is, what are indications for oxygen therapy, or what is the purpose for oxygen therapy? And we're going to allow 30 to 45 seconds for the learners to answer this question on their own in the chat box before we open it up to our experts. So in your own description, why do we use oxygen therapy? What are the indications and what is the purpose? Why do we use oxygen in our patients? It seems like a basic question, but we need to know clinically when we use oxygen. And I think that's more the question here. So good. So Salma answers for hypoxemia, which is correct. To improve oxygenation, which is correct. I like to take it back to kind of the really basic reason why we need oxygen in the first place. So I'm going to ask my panelists, maybe Dr. Santiago, why, thanks. I kind of felt like you would want to answer this question. So what does oxygen do in the body? Why do we need oxygen?
Thank you so much, Doctor, for the question. So the summary of why we need oxygen is actually two words, that is oxidative phosphorylation. We know that the electron transport chain, the mitochondria, is the source of the ATP, that is the source of energy for the cells and for all the biological activity that occurs in the cell. So in order to buffer the hydrogens that they go through the electron transport chain, we need oxygen. Oxygen is going to receive this hydrogen and is going to produce water, and that's how the mitochondria avoids acidosis. Also in the Krebs cycle, we are going to produce CO2 through the carbons in the intermediates in the Krebs cycle. So the oxygen also works as a buffer, since it's going to produce CO2. So in short, we need oxygen for the oxidative phosphorylation. And in terms of the most important indication for oxygen therapy, we can say that generally speaking, hypoxemia is the gold standard indication. And there are different conditions that can be divided in acute and chronic conditions. For acute, we can think in shock, sepsis, trauma, cardiac arrest, resuscitation, anaphylaxis, or carbon monoxide poisoning. And in terms of chronic conditions, we can think in COPD or cystic fibrosis or pulmonary fibrosis are among the most common conditions where we are going to prescribe oxygen therapy.
Excellent. Thank you. That was a very detailed answer. But essentially I'm just going to summarize if you don't mind. Every cell in our body requires oxygen for respiration and metabolism. And I like to think of the cells themselves, because what we see clinically are problems with the patients, but every cell needs oxygen, and cells make up our tissues, which make up our organs, which make up our organ systems, which is what is affected when we have hypoxemia. And as Dr. Santiago mentioned, there's many reasons and many causes of hypoxemia: pneumonia, cystic fibrosis, any condition that leads to hypoxemia. So going back to the initial question, the indication for oxygen therapy, if we were to answer that in one word, is hypoxemia. How do we know someone is hypoxic? We have to measure that typically with a pulse oximeter. And the purpose of oxygen therapy is to raise the oxygen levels to suitable goals that will ensure that each cell has enough oxygen to participate in respiration and metabolism. So that's a very great question. It's a very basic yet broad question. And I think it's really good for all of us, no matter how much training and how much experience we have, to really understand the basic building blocks of our bodies and why they need oxygen. It's why every single one of us breathes. So great answers in the chat box as well. To make up for the lack of oxygen: respiratory failure, ARDS, carbon monoxide intoxication, hypoxemia, hypoxia, all great answers in the chat box. So thank you for your participation. I would like to read one key point. We're going to have some key points along the way here. This is from the British Thoracic Society Guideline for Oxygen Use in Adults in Healthcare and Emergency Settings. Oxygen is a treatment for hypoxemia, not breathlessness. Oxygen has not been proven to have a consistent effect on the sensation of breathlessness. in non-hypoxemic patients. So it's important for us to recognize, and this comes up through a lot of the additional questions, oxygen is used to treat low oxygen levels or hypoxia or hypoxemia, and does not necessarily support the act of breathing or the sense of breathlessness. Okay, so what are the optimal targets of oxygen therapy and when should it be titrated up? This is a very common question we've been asked several times. So we'll give you just a few minutes in the chat box, or just a minute in the chat box. So what are the targets of oxygen therapy and when should we titrate up? So we'll let the learners and participants answer first, and then we'll get the experts to weigh in. What goal SpO2 do we target? Thank you, Dr. Gosa. It depends on the cases. Sabine says greater than 95%. Brigitte says at least 90%. Tola, greater than 92. Mkindi, 92, 93, 92. So we can see that the numbers are variable all over the place. And I like the very first answer, which says it depends on the case. Great answers, between 90 to 95. Wonderful. The thing I also would like to say that I enjoy seeing in the answers in the chat box is nobody says 100%. So we'll talk a little bit about that too. So from our panelists, what are the optimal targets for oxygen therapy and when should it be titrated up? What are some of the opinions from our experts? Dr. Fred? Dr. Fred and Freddie, both unmuted. So I'm going to let the two Freds comment on this one.
All right. I think what's really important is to understand that pulse oximetry is not very accurate above 95%. So when you're in an oxygen, you want to conserve your oxygen and you have limited resources for oxygen. You need to be careful that you don't use more of it than you need to. And pulse oximetry, I think people think it's more accurate than it really is. What I mean by that is, for example, if I read a saturation of 96% on a patient, I might measure a blood gas and get a PO2 of 200 or higher. And that would not surprise me at all, because again, between that range of 95 to 100%, pulse oximetry is not terribly accurate. It gets very fuzzy. And so we certainly don't need a PO2 of 200 in our patients who are hypoxemic, and we want to conserve oxygen anytime we can. So I think trying to go above or having a target above 95% would risk using more oxygen than you need.
Great point. Thank you, Dr. Main. Freddie, what were you going to say?
I agree with Dr. Fred in many of the issues he has appointed, but I had to say that titration of oxygen is a very important issue, because a goal, a basic goal for many of the patients must be 92%, 92%. None of our patients must be under these levels of oxygen, but it depends effectively by the situation. Is different, for example, for the pregnant patient, and it's important to keep in mind that one side is the oxygenation, and the other important issue is the mechanical ventilation. Oxygenation is necessary for those patients that preserves their mechanical ventilation in good conditions. Yeah, it's important this, because if the patient is in a bad condition of mechanical ventilation, they need supporting for this situation.
Agreed. Completely agree with both of you. Thank you so much. So I think it can be very confusing. And I think we can also see from the answers in the chat box that there are a lot of different numbers that people will report as the goal. I think Dr. Fred Means' point that pulse oximetry is not only doesn't always correlate perfectly with arterial blood gases, but we also need to recognize that not everyone has access to arterial blood gases. So pulse oximetry might be the best we have. There's also a very robust discussion internationally about the use of pulse oximetry in dark-skinned folks, because the pulse oximeters are less accurate oftentimes if you have dark pigmented skin. So there's just so everyone knows, there's a lot of discussion about this and a lot of research happening right now, and people are reassessing all of the different manufacturers of pulse oximeters and trying to figure out the best ones that are the most accurate for all patients. So there's a lot of things to consider, and for our learners, having all these different numbers and all these different considerations can be quite confusing, I would imagine. And then those are factors outside of the patient factors. The patient factors is the patient pregnant? Is the patient in septic shock? Is the patient a COPD patient? Is the patient living at altitude? So all of these other things must be taken into consideration to identify the proper target for these patients. Luckily, we have Friends, and Friends are developing algorithms and clinical guidelines for us, especially through the COVID-19 pandemic. So this algorithm comes from USAID, the World Federation of Societies of Anesthesiologists, opencriticalcare.org, which is one of our favorite resources that we will, are sharing throughout the sessions, but also today. And our friends at UCSF, which is a university just up the street from Stanford. Really great resources here. But essentially, you can see in this box here, titration and SpO2 goals, which is the simple answer to the question that was just asked. So for most adults and children, you want to maintain an SpO2 greater than 90% for almost everyone. In pregnant patients, there is a range that you'll see, but at least 92 to 95%. If the child or adult has signs of multi-system organ failure or multi-organ failure, any sort of end organ problem. So that can be heart, lung, mental status changes. Then you want to target a higher level of oxygen. So that's greater than 94%. Avoid SpO2 greater than 96%. And we'll talk a little bit more about that. There's two reasons for that. One is oxygen toxicity, and the second is overutilization of a precious resource that we may not have a lot. So great. So the learners can go through this algorithm. Again, you can click on it. It's in the Learning Resource Center. You can read it on the Learning Resource, or you can print it out if you click on the link. Some other key points. PATH and the World Health Organization in 2017 determined that oxygen should be considered an essential part of a complete healthcare system and is required treatment for a range of conditions across disciplines and age groups. This is a significant statement from the WHO. It essentially designated oxygen as an essential medication, which surprisingly, before 2017, oxygen wasn't seen as an essential medication. So it's a really big deal for everyone to recognize that oxygen must be present in all of our healthcare systems, regardless of location. And then there's additional oxygen guidelines that come out of Australia and New Zealand. Oxygen saturation measured by pulse oximetry should be considered a vital sign and documented with other vital signs in patient assessment and management. So this is another big statement, which a lot of us may take for granted, but is very important, that SpO2 should be considered a vital sign. So when you're checking vital signs on your patients on the ward, in the emergency room, in the ICU, in the operating theater, no matter where you are, you need to make sure that oxygen, SpO2 is also checked. And with that, if you're going to prescribe oxygen therapy, it should be documented in the patient's chart as a medication. So it should be a prescribed therapy. There was another group that went through oxygen therapy and specifically considered areas with limited resources. And there's, if you click on this chart, you actually get another link from Lifebox. But they also point out that if you have shock or alteration in mental status or any sort of end organ damage, that your SpO2 target should be greater than 94%. And they state for pregnant patients that it should be 92 to 95%. So there's a lot of numbers. You don't have to remember them. You just have to know where these wonderful resources are and how to access them. And again, they're all in the Learning Resource Center with their links. Okay, let's ask the learners the next question. What are the preferred devices in administering oxygen? And again, these questions are direct from you, from the learners. So this is a question from several learners. What devices are preferred in administering oxygen? So we'll give about 30 seconds for this. So someone says a pulse oximeter, which is great. Another person says a non-rebreather mask, which is also great. Nasal prongs are very common. Face masks, nasal prongs, non-rebreather. Depends on what's available, which is probably the best answer. Depends on patient requirements. Great, excellent. So how would our panelists, maybe ready, do you mind taking a shot and addressing what the preferred devices are and how you think about this when you're taking care of patients?
Thank you, Anna. So we have several options. I think the best answer was answered in one of the participants here by the chat box. It's based on what's available to you and depending on the patient, the degree of hypoxemia. So several methods are there using nasal cannula, nasal prongs, simple face mask with reservoirs, non-invasive mode of ventilation if you go up with CPAP or BiPAP or high flow nasal cannula, and to the extent of requiring mechanical ventilation. And this all depend on the patient's condition and what's available. And some other factors that may determine is the source of oxygen that's available in your setup. So what is available and what the patient's condition is determines what would be the mode of oxygen delivery for our patients.
Excellent. Yeah, I completely agree. It depends on first what's available, because you can't offer something that isn't there. And then you have to look at the patient factors and determine what the level of oxygen that patient needs. So I think we have a good link if we click on there, oxygen delivery devices. This is from a website that we're going to have a list of resources that we share, but it's called covidprotocols.org. And you can see there's lots of different sections, but this one goes through inpatient management, and through that it has a section on oxygen delivery devices. So it talks about different flow rates, but it goes through these devices: nasal cannula, simple mask, non-rebreathers, Venturi masks, high flow nasal cannula, BiPAP, CPAP, and all of these are considered non-invasive forms of oxygen. So non-invasive oxygen, from lower flows to higher flows, I would say goes from the nasal prongs to the simple mask, and then you can bump up to Venturi and non-rebreather. The non-rebreather gives you the highest flow of oxygen before you get to non-invasive positive pressure ventilation, such as CPAP or BiPAP. So what flows do we use with a non-rebreather mask or a mask with a reservoir bag? Bryant Shannon, can you answer that question? What flows do we use?
Yeah. So
Dr.
for the non-rebreather mask that you put on a patient, it's essentially you're breathing from a direct reservoir source, like Dr. Crawford said. And so it's really dependent on how tachypnic or how fast the patient is breathing. Initially, when I'm trying to stabilize patient who has a really low oxygen level, I'll crank up as high as our oxygen setting will go on the wall, and then I'll try to slowly wean it down to match their respiratory rate, because what you really want to avoid in this situation is a patient who is breathing faster, and their liters per minute that they're asking for with their tachypnea is more than you're actually supplying, because then they start actually just breathing in room air through the holes in the sides of the mask. So I like to start at about 15 or higher, and then kind of bring it down if they're less tachypnic, if they're looking more stable, and their oxygen levels or O2 saturations are starting to get high. So start high, bring it down, but really it's kind of based on how much oxygen they're breathing every minute.
Yeah, great. And so a couple folks in the chat answered 10 to 15 liters per minute, and I think that's a great answer. I think in order for the reservoir bag to maintain inflation, we need to be running at least 10 liters per minute. And above 15 liters per minute, we actually start to waste oxygen. So in places with low oxygen supply, I think staying within that 10 to 15 liters is pretty helpful guidance. So what determines the duration of time oxygen therapy is needed, and how do we wean oxygen? Again, we're gonna give just half a minute or so for learners to answer that, but I'd love for my panelists to be thinking, when do you turn down the oxygen? How do you know patient's been on oxygen long enough? So we'll answer that question in just a second. So someone says the patient's condition, so reassessing the patient and checking an arterial blood gas analysis. The next person says SpO2, because not all of us have access to arterial blood gases. Depends on the patient's condition. If the patient starts to improve, we start to de-escalate. It depends on the patient's hypoxemia and pathology. If the patient is out of distress and meeting their SpO2 targets, depends on underlying causes. All of these are great answers. Dr. Dati, can I ask you to take this question and help us understand your process for de-escalation or titrating down on oxygen?
Yeah, thank you very much, Anna. I think the best way to go about it is the way you escalate the treatment or the therapy, you de-escalate in the same manner. Now, I want to emphasize that you try to address the primary cause of the hypoxemia when you start the therapy. If it is obstruction, you try to relieve it and so on. And then with your SpO2, then I want to emphasize what I think Freddie mentioned, where you don't have facilities for arterial blood gases to conserve this precious commodity. You can now combine with the clinical features of the patient. For example, you can see the respiratory rate coming down, everything stabilizing along with the target saturation you set, you're getting it, then you try to reduce the flow. For example, if you're using high nasal flow, high flow, then you find yourself coming back to nasal prongs and then still achieving the target and so on. So really you can't say the duration, but it depends on how fast you are addressing the primary cause of the hypoxemia or hypoxia.
Excellent points. I love that you point out you cannot say there's one duration because every patient and conditions are different. Excellent. Thank you so much. That was a very clear answer for me. I like how clear your thinking is most of the time, Dr. Dati. So I'm happy to have you here. Again, we're going to go back to the resource. If you click on that question, it brings us back to covidprotocols.org, and you can see they actually have an oxygen weaning pathway. For those of us who are not as familiar with using oxygen therapy in patients, this may be a very helpful resource, but it talks about the different oxygen delivery devices. It talks about targeting different SpO2 goals. So this is an excellent additional resource for our learners and participants to go through. It's covidprotocols.org, and anyone can access it. The whole point is that it's available for everyone. And it will go through in more detail Dr. Dati's excellent answers. So we talked about this a little bit, but one of the questions from our learners was, what are the different methods of oxygen therapy? And I think about this a couple different ways, but let's see what our learners think. So when you think about oxygen therapy and the method of delivering oxygen, what are the different methods? Different methods of oxygen therapy. Great. Invasive, non-invasive. Some people are talking about oxygen delivery devices such as nasal prongs, manual and automatic. Great. So when we talk about different methods of oxygen therapy, I actually think there are a couple different ways to frame or categorize the methods of oxygen therapy. And I think about it in two ways. One is the oxygen supply, and then the other is the oxygen delivery. And then I think about the oxygen delivery devices, and I think of low flow versus high flow. And then I think of invasive and non-invasive. I'd like to hear from some of our panelists. How do you think about oxygen therapy if you were to answer this question?
Dr. Anna.
Yes, sir.
I think that the way you have commented is it's correct, is right, because there are many ways to interpret this question, and many sources of oxygen, like cylinders, oxygen concentrators, plants, liquid tanks, must be taken in account to know what are your facilities, and at the same time, the delivery of oxygen is an important issue. You have to choose different ways, invasive or non-invasive, to treat the different conditions, and it marks the right device you have to use with the patient. And it's important to take into account the devices depending on the flow of oxygen, low flow or high flow, that this need, if the patient needs more oxygen supplementation. This is an important, I think this is the way.
Since we're pairing the Freds, I'm wondering what Dr. Meem, how he thinks about different oxygen delivery methods. How do you have it categorized in your head?
Yeah, so there's many ways to think about this, I guess. The big separation is which ways, the separation from delivering oxygen through an endotracheal tube, meaning very invasive, I have to intubate this patient. That's one category. Do I have to intubate this patient, or can I give oxygen without intubating the patient? The second one, it would be whether I have to give oxygen with some means of ventilatory support, where I would need to support ventilation as much as oxygenation. So that would include devices to help with breathing, like non-invasive ventilators and things of that sort. So then if I don't need to support ventilation with the oxygen, then I'm using various masks that we've already talked about.
Excellent. I think about it the same way, probably because you're my mentor and you taught me a lot that I know. But I think, you have to really determine early whether this is a pure oxygen problem or whether you're also having problems with ventilation and or work of breathing. Because if you're having problems with ventilation, you're going to have to support that patient with either non-invasive positive pressure, or perhaps they may even need mechanical ventilation. Similarly, if they have an increased work of breathing, then you need to utilize devices that help not only with oxygenation, but also with the work of breathing. So I like the way you organize that, but it's probably because I learned from you. So let's see what our resource says. This is the British Thoracic Society guideline on the use of oxygen in healthcare and emergency settings. So again, if our learners are looking for guidelines, this is a free open access online resource that goes through different indications for oxygen. And also it goes through some of the devices and has some algorithms. So if you're looking for a guideline, because this is something new to you, then please click on this link and go through this resource, because it helps, I think, for us to be able to identify, if we see these patients in extremis often, we're very skilled at recognizing when a patient needs more help. But if this is new to you, you work in a clinic and not a hospital, then this may not be as obvious to some of us. So I think some of the key points that I put in, and I welcome my panelists to contribute to these key points, but I think that oxygen therapy treats hypoxemia. It does not assist with ventilation or work of breathing. The methods of oxygen therapy can be considered in several ways. The sources of oxygen, such as oxygen cylinders, concentrators. Some of us are lucky enough to have oxygen plants or large liquid oxygen tanks at our facilities. The delivery of oxygen, is the oxygen going to be delivered invasively, such as a mechanical ventilator, or are we going to use non-invasive oxygen therapy? And that can range anywhere from low flow devices to high flow devices. Patients must be monitored continuously to determine their needs for oxygen and their needs for supportive breathing. So it's not just oxygen. Sometimes the patients need even more help with ventilation and the work of breathing. Pulse oximetry must be available and used to assess patients receiving oxygen therapy. It's not necessary to have arterial blood gases. If you have them, it's fantastic. It's a good confirmation of what's going on. But if you have a pulse oximeter, at the very least, that's great. If you don't have a pulse oximetry device, we encourage you to get one, because we think they should be used with every single vital signs check. The best oxygen source and delivery device is the one that is available. So use what you have and recognize that even giving some oxygen is better than no oxygen in a lot of these cases. Great. Okay, our next question is very interesting. What are the complications with oxygen poisoning, excess oxygen administration, and prolonged use? And I think this question goes well with the one previously that says the duration of oxygen, how long can we use oxygen, etc. So we will again give a few minutes for people to answer in the chat box, and then I'm going to go ahead and just let everyone know that I'm going to call on Dr. Freddie to answer this question, because I think he might be somewhat of an expert in this. Good. Maria Cristina says in premature babies, oxygen may actually lead to blindness. That's a good point. We'll talk more about that. Oxygen toxicity. We'll talk a little bit more about what that means. What is oxygen toxicity? Absorptive atelectasis. I love that answer. Thank you. Yes. From Jonas. Muscle twitching.
Wonderful. Okay, that's wonderful answers. Oxygen as a drug has many implications in toxicity, as the liberal use of oxygen may find many complications because the cell uses the excess of oxygen in other mechanism for cellular damage. Is basically the point in this issue. So hyperoxia, those oxygen molecules that are free may be toxic for many of the organs, like lungs, like kidney. The excess of oxygen depress the secretion of many important substances that maintains the vascular arteries and veins in good function, and the excess of oxygen is related with the production of molecules called reactive oxygen species that are toxic for many of the cell functions. Oxygen it's correlated with retinopathy in newborns, so a type of proliferative retinopathy, and in the brain hyperoxia it's associated with direct cerebral toxicity, especially in neonates, in neonatology and critical patients. So we have to keep in mind that oxygen may be controlled and monitoring, avoiding the excess of these toxic potential molecules of free oxygen.
Excellent. Thank you, Dr. Freddy. I want to make one clarifying point. If your patient is hypoxic, give them oxygen. If your patient is hypoxic, give them oxygen. You can use the SpO2 goals that were outlined in the escalation and weaning algorithms. But if your patient is satting well, so their SpO2 is 98 to 100%, then you can start to wean down the amount of oxygen given. So although oxygen toxicity is a concern, it's not as much of a concern in a patient who is hypoxic because they still need the oxygen, right? So we don't want to take away the oxygen too soon. Any other thoughts from the rest of our panelists about hyperoxia and oxygen toxicity? How do you look for it? How do you manage how much oxygen you're providing? Any other thoughts?
Ana Maria, if I can make a comment, I fully agree with the comments that you made about that the priority is to treat the hypoxia. And I think that we need to highlight the word drug, because oxygen actually is a drug. And as we comment in the chat, for many years, I think that we thought the oxygen as something that we could give like freely. And the same happened with the fluids in many conditions. So I do think that, of course, when the patient is hypoxic, we need to treat it. But at the same time, we should always keep in mind that oxygen has a therapeutic window, and there are many potential complications of hyperoxia. And as Dr. Freddy mentioned, the production of ROS and RNS is something very well established. I remember that in the past, I think 15 years ago, in all the patients with heart attacks, we were giving straightforward oxygen, and then several studies have shown that actually if the patient is not hypoxic, the outcomes are worse. Okay,
exactly.
So
and stroke too, isn't it? Yeah.
Yes, and in the past we were giving oxygen like, oh yes, by default. So I think that that's a discussion and something that we have to bring always.
Agreed.
To the conversation, that to bring
I like the term you use, which is therapeutic window. And I think that's important to recognize. I think I made the comment about hypoxemia and giving oxygen because in a lot of locations, we may not have the same clinical gestalt, and we may not have the same access to things like arterial blood gases. So if we have a pulse oximeter, we can use that to determine our therapeutic window of oxygen. So excellent points. So oxygen therapy can be. Oh, sorry. Yeah, Dati and Reddy at both. Let's get the discussion.
Okay, Reddy at first.
Thank you. Okay, thank you. I just wanted to mention that in my experience, I've seen many healthcare providers setting SpO2 of about 100 for most of the patients, critical patients. But that shouldn't be the case, and there are certain guidelines that we need to follow. And that oxygen is a drug, it's a therapy, and it has its own side effects. And easily can be summarized in a systematic way. Oxygen can be a very toxic drug on the, for example, in a systemic way on the brain, it has a vasoconstrictive effect. On the heart, it has vasoconstrictive effect. On the lungs, the nitrogen washout can result in atelectasis. And also for patients like COPD patients, the oxygen, the respiratory drive can be decreased because of oxygen therapy, and that can increase the CO2 of the patients. So it has its own significant side effects, and it's usually neglected. We see SpO2 of 100 and we do nothing. We don't taper, we don't wean patients is of the oxygen there, and that shouldn't be the case. Thank you.
Also a problem, Rediat, when we have oxygen going and the patient is SpO2 at 100%, not only from a cellular toxicity standpoint, but also from a resource utilization standpoint, isn't it? Like we are also wasting oxygen if we don't need it. Dr. Dati, what were you going to contribute? Yeah.
Yeah, thank you. My point is preventive, which has worked for me during my residency days. My teachers taught me, like I'm giving an example in the patient that needs invasive oxygen therapy or ventilating. So when you're commencing mechanical ventilation, I was told that I have two options. You have your target, and then you can start with the FiO2 of 1, that is 100%. And then you now bringing that over time, maybe every half hour or an hour, and you're checking and you're getting the target saturation. And our target, we're told, is FiO2 of 0.4. That's 40%, because when you eventually wean the patient, you're going to start those non-invasive oxygen therapy. The other way to start, you can start with 50% oxygen, and then you either go up and then you come down. So that way you will be really in that therapeutic window that we mentioned earlier. Thank you.
Thanks, Dr. Dati. Yeah, I think that's an excellent point. And I think many of us do it similarly in that if we were going to, for example, intubate somebody and place them on a mechanical ventilator, many of us would start with an FiO2 that's high and reassess frequently and bring that FiO2 down as quickly as possible. And I think Dr. Santiago pointed out very astutely that we want to target an FiO2 of less than 60% as soon as possible, because above that is where we start to see the problems with oxygen toxicity. So if your patient is saturating, if their SpO2 is adequate, then try to get your FiO2 down to 60% or lower if you can. Any other comments from our panelists? This is a great discussion. Okay, great. So some of the key points, and again, I encourage our panelists to contribute to these if you see others that I missed, but oxygen therapy can lead to retinopathy of prematurity in neonates. It can lead to oxidative stress throughout the entire body, so it can affect all the cells and organ systems in our body. We want to monitor the SpO2 frequently and use it to adjust the flow of oxygen either up or down based on our SpO2. We don't target an SpO2 of 100%, and we wean the oxygen as soon as possible, aiming to decrease to an FiO2 of less than 60% or 0.6. Okay, this question is for everyone to answer in the chat box. It's a true/false question. Oxygen delivered by non-rebreather or mask with a reservoir bag at 15 liters per minute is considered high flow oxygen therapy. And I put this question in there deliberately because there's a little bit of debate about what defines high flow oxygen. We didn't do a poll question, but a lot of people are saying true. A couple people are saying false.
Yeah.
So I think the point of this question is that there is debate on how we define high flow versus low flow oxygen. I would say false, and I would say false because in my practice setting, we have access to high flow oxygen therapy. High flow oxygen therapy is is a completely different device. It's not oxygen delivered at higher flows. It's actually a specialized device that heats and humidifies the oxygen. And the flows that are delivered with high flow oxygen therapy are much higher. They're usually at the very least 20 to 30 liters per minute and can go up to 40 to 60 liters per minute. So high flow oxygen therapy is something completely different than just turning up the flows on oxygen. We had covered this in previous sessions about high flow oxygen therapy. We like these two videos. There's high flow oxygen therapy part 1 and high flow oxygen therapy part 2. So I don't think we'll play the videos in this session, but we can talk about how we use high flow oxygen therapy. And one of the things in the videos is the definition of high flow. If you were to measure how quickly a normal adult is breathing at rest, it's at least 20 to 25 liters per minute. So if you think about our oxygen delivery devices, the non-rebreather is the mask that has the highest flow, which goes up to 15 liters per minute. If we're breathing normally at 20 to 25 liters per minute, that flow is less than our normal breathing. The high flow oxygen therapy device meets or exceeds the flows that we breathe naturally. So those devices actually breathe at or higher than normal flows. And that is what I consider the definition of a high flow oxygen therapy device. Does that make sense? And do the panelists have any additional questions?
I agree with you, Anna. Yeah, and additionally, the high flow devices has been a great advance in oxygenation supporting, because there are many information about the benefits in reducing many of the final status of ventilatory support. Yeah, there are many information and studies that reports the reduction in the incidence of mechanical ventilation of these devices, and I'm agree with you that the high flow high flow device is when it is more than the normal ventilation for an adult. Yeah.
Do you think we should watch the video, Freddie? We've seen it before, but.
Yeah.
Dr. Anna, Dr. Freddie, I fully agree with you, and we have to acknowledge that there are some advantages in the high flow therapy devices. As Dr. Anna mentioned, the fact that the patient is going to receive a heat and humidified gas improves the airway hydration, and it helps to provide a better respiratory support through a higher FiO2. It has likely a PEEP effect, and also helps to decrease the dead space. Okay,
that's right.
Something that
so
doesn't
it
happen.
replaces the dead space with oxygen, which is thought to help the patient in gas exchange and work of breathing. Yeah. Great. There's a really great question in the chat box that I'd like to open up to the panelists, and it's, can you combine nasal prongs and face masks? What do the panelists think about that? I would say yes, you absolutely could.
I'd say yes too, Anna.
Yeah. Why would that be beneficial to combine them?
I would say because you would be able to deliver a bit of a higher FiO2. For example, if you have a face mask with reservoir that's able to deliver FiO2, a maximum FiO2 of about 85%, if you combine it with nasal prongs, then you might be able to achieve 100% FiO2 with that one, with still low flow of nasal prongs. So still beneficial, I would say.
Yeah, I'd also just think that some patients are better at breathing through their mouths and some are better at breathing through their noses. Some of us have problems breathing through our nose. So, so that might actually be an additional benefit. What are the advantages and disadvantages of high flow therapy devices? I think we should watch the video, actually, at least the first one, because I think there's still a little bit of debate happening in the chat box. So let's watch
what is
this.
high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC, or even HFOT or HFT, or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high flow humidified oxygen delivery device.
So I'm going to stop there, but I think this is the key here for us to recognize is that when we're talking about high flow oxygen therapy, we're actually using an additional device. This is not just a non-rebreather with higher flows. So it requires a specialized device to deliver high flow oxygen therapy. So when we say high flow, that's why we think this is different than a non-invasive device with higher levels of flow on the flow meter. So I encourage the audience to watch the second video, which goes into how to set the flow rate, the FiO2, and the temperature, which are the only 3 settings on a high flow oxygen therapy device, which is important to recognize because there's no volume set, there's no respiratory rate set, there's no pressure set. These are the only 3 settings. So you're really just setting the flow rate, the FiO2, and then the temperature. So high flow oxygen therapy is different, and it is a higher flow than what you can do with just a regular non-rebreather. So the advantages we already talked about. Dr. Santiago, do you mind summarizing what you think the advantages and disadvantages are, since you kind of alluded to this already?
Sorry, it's okay.
No,
Absolutely.
you're great.
Yeah, some of the advantages of the high flow therapy, as you mentioned, are the fact that the patient is receiving a gas that it has been heat and humidified, so the patient tolerates better. And in point of fact, the literature says that this helps to have a better cilia system that is important for the airway clearance. So also the patient doesn't have the typical process of a dry airway. And it helps to have a higher FiO2 because of the high flow, and it likely has a PEEP effect without having to have the patient ventilated or with the non-invasive ventilation, and also it helps to decrease the dead space.
Great, thank you so much. So key points after that: normal adults breathe at a flow of 20 to 30 liters per minute. So that's what you and I are breathing now. And that means a normal adult that's not in distress. So if someone is sick, so patients in respiratory distress, they're going to breathe more quickly. So their flows will be even higher than the 20 to 30 liters per minute. Oxygen or high flow oxygen therapy requires a special machine to generate the flow. And those flows are generated at higher rates than the normal flows from an adult patient. High flow oxygen therapy requires specialized nasal prongs or prong devices. It's not a normal nasal prong that's used. And high flow oxygen therapy requires heat and humidification. As you can imagine, with those very high flows, if you were just to give cold, dry air, the patient's mucous membranes would dry out very quickly and they would have nosebleeds and it would be very uncomfortable for the patient. So heat and humidification is required with high flow devices. It does not assist with ventilation or CO2 clearance. So this is not a ventilatory device. This is a pure high flow oxygen therapy device. How is oxygen therapy provided when a patient is in prone position? This is a question from the audience. So how do we provide oxygen in prone positioning? We can let the audience answer in the chat box. So one person says it's better to use an invasive delivery device. Another person says nasal prongs or cannula, which is definitely not an invasive device. So what do our experts think? Can you deliver oxygen to patients that are in prone positioning? And if so, how would we do that? Bryant, Dr. Bryant.
Great question. We actually deal with this a lot in our ICUs. And so you can actually deliver really any oxygen therapy that you could deliver in the supine position, the prone position. So they sort of work complementary in that we're kind of trying to improve ventilation while also improving by delivering a higher level of oxygenation. In our patients who are mechanically ventilated, we use teams of nurses and respiratory therapists to help us flip the patients onto their stomach for a set amount of time of day. But patients with high flow and nasal cannula actually do quite well. We actually try to encourage them to lay on their stomachs for as long as they can to hopefully prevent escalation of oxygenation needs and needing to be intubated.
Excellent. Yeah. So any oxygen delivery device, whether it's invasive or non-invasive, can be used in any patient position. But this is a very common question that providers have around prone positioning. How do you do prone positioning in a patient who's non-intubated? How do you do prone positioning in a patient who is intubated? What about the pregnant patient? And so if we click on this question, it takes us back again to covidprotocols.com or .org rather, and it has an entire section on prone positioning. So intubated self-proning and the non-intubated patients proning with COVID-19 and why this works. And it does improve oxygenation. I'm going to call on Dr. Leese to share her experience. She works in the emergency department often. Dr. Leese, do you use prone positioning in the emergency department for hypoxic patients? Not sure if Dr. Leese is still with us, but essentially you can use prone positioning in any patient. The next question is, how do you manage, and again, these are all questions from our learners. How is ARDS managed and what ventilator mode?
Yeah.
Oh, sorry, Dr. Leese. Yeah, go.
Yeah, sorry, I was muted. I couldn't unmute myself. Okay, thank you. Yeah. So we can use prone position in patients in ED, but because of the movements around in the department, we have to be very cautious to so that they don't remove. So you will select your patient very well, like the patient who are able to collaborate with you, and so that they don't dislodge it without you knowing. Otherwise, in this COVID era, it has been helpful as it helps buying time.
Thank you. So having a cooperative patient is an excellent point. If your patient is not cooperative, it might be quite a bit more difficult to get them to comply with that position. But we often, as others have pointed out, try to get patients, even if they're just on nasal cannula, on the floor, on the ward, regardless of location, regardless of oxygen delivery device, try to get them in prone positioning if possible. Okay, this next question is a very, very big question, and it would almost require an entire separate session to answer. So we're going to be brief and, in fact, really just introduce you to some resources so you can read more about this. But how is ARDS managed, and what ventilator mode is used for ARDS? So we're again going to give you some time in the chat box to answer this. How is it managed? So what are some key points in managing ARDS, and more specifically, what ventilator mode is used for ARDS? And Dr. Meem, I'm going to call on you for this, so get ready. So how do you manage ARDS? What are some key features in the management of ARDS, and what ventilator mode would you choose? Let's see if we can get some answers in the chat box here. Diuretics, I like that answer. High PEEP, that's something we can discuss. I see AC, that's definitely something we can discuss. Lung protective techniques, that's an excellent point. Lung protective, great. Some people are saying CPAP, so I'd like to address that. AC mode from Eric. Hello, Eric. Wonderful. Okay, Dr. Meem, take it away. How do you treat ARDS? What ventilator mode would you choose?
Well, first of all, to make it a kind of short question, not a long drawn out one. ARDS is generally indicates a serious lung injury. You still, in those patients, would try to avoid having to intubate them and put them on a ventilator if you can, but most of them, of course, have a serious enough lung injury, so they require intubation, not just for oxygenation, but because their work of breathing is difficult as well, and they need support with the ventilatory work that a ventilator provides. So most of these patients do get intubated. As far as the mode of ventilation, assist control is the most popular mode of ventilation, and that is not because it's inherently better than some other modes of ventilation. It just happens that for whatever reason, the ARDSNet study group, and I don't honestly completely agree with them on this, but they chose assist control. I wish they had chosen another mode of ventilation, but they have, by choosing that in most of the ARDSNet studies, they have codified that pretty much everyone uses assist control. It's okay. You could use other modes of ventilation as well, but the point of assist control, as with some other modes of ventilation, is you're really completely taking over ventilation for a patient, but allowing the patient to trigger some breaths if they choose to. Do you
use PEEP in your ventilator settings?
Yeah, so other than just the mode of ventilation, then there are other things to pay attention to. And most people who ventilate patients with ARDS are trying to focus on small tidal volumes in the range of 4 to 6 milliliters per kilogram per ideal body weight, and using PEEP to improve oxygenation. And there's debates about whether high PEEP or low PEEP strategies work, but most of these patients require 10 centimeters of water PEEP or more to improve oxygenation. The third parameter that's or adjustment that's paid attention to is the driving pressure, and people now are thinking that the driving pressure, which is the difference between the peak and the PEEP level, is really important. So there's more that could be said, but that's in a nutshell.
Great, that's a nice summary. Let's click on the link and see what we get. This link is going to take us to opencriticalcare.org. It's another one of our favorite resources. This is a pocket reference respiratory card, and it goes through different oxygen sources and delivery devices, respiratory care setup and monitoring. But it also goes into respiratory mechanics, which talks about a lot of the parameters that we either set on the ventilator or that we measure on a ventilator. And it talks in detail, as much detail as you can put on a respiratory card, about lung protective ventilation here. And so it talks about when to use it. It talks about the definition of ARDS. And that includes the Kigali modification. So the Kigali modification of the definition of ARDS includes practice settings that do not have access to arterial blood gas analysis. So it uses the SpO2 instead of ABG. It talks about ideal settings for tidal volume, which Dr. Meem said was 4 to 6 milliliters per kilogram predicted body weight, not actual body weight, especially important here in the United States where our patients are often obese. You don't want to give them larger than needed tidal volumes. The different pressures, respiratory rates, and it talks about the FiO2 to PEEP ratios in these tables down here. This is something you can print out, or you can just pull it up on your phone. It also has volume control versus pressure control. It talks about adjunctive therapies for ARDS hypoxemia, such as fluid management. Many people mentioned in the chat box that we should be using diuretics or keeping the lungs dry. Whether or not to paralyze the patient or use muscle relaxants, whether or not to put the patient in prone position with ARDS, and some other vasodilator therapies. So an excellent resource all on one resource. So I encourage you to look at that at the very least and either print it out or put it on your phone or computer, ideally. Some of our favorite resources. So this concludes the oxygen therapy component. We still have much more ground to cover, but covidprotocols.org. You can see these are live links. So on the LRC, you can click on these links and find everything we just talked about as far as our references. Oxygen guidelines, the quick reference card for respiratory settings. Here's some order sets for your hospital. If you need to put in orders, this will give you some templates that you can use for doing order sets. The oxygen therapy wall chart, which targets limited resource environments. Another guideline for oxygen use, and then the 2 videos on high flow oxygen therapy. So we're going to move on now to critical care. How is critical care provided outside of the intensive care unit? I'm going to ask Dr. Freddie to help us with that.
Oh, thank you, Anna. Critical care may be provided in many places of our hospitals and institutions. It's important. The most important thing is the provider. What they know about critical care and the capacity or the availability of early starting of procedures. Many places in our hospital, for example, we have conditioned many wards, hospitalary wards, post-anesthetic care units, many surgery rooms for provide critical care in these times of pandemics. So it's the most important thing is have the people, have the staff, the personal staff, and to know what are the capacities or facilities you have in your area to provide the basic devices and care for your patients.
Excellent. Thank you, Dr. Freddie. I think you described it exactly. So critical care is a continuum. It can occur in any location. And the ideal situation is that you're delivering time sensitive or time critical care where it's needed. This can occur on the street with bystander CPR. This can occur in an ambulance or some sort of patient transport, emergency patient transport. It happens in the emergency department. It happens on the wards. And it also happens, of course, in an intensive care unit. I think recognizing that you definitely need staff to not only recognize that there's a critical problem, but also to deliver appropriate time critical care are keys to that. I would just add that it also requires good hospital systems. You need a system that can take care of patients outside the hospital and bring them in emergently. You need a good system that recognizes a patient in distress on the ward. So in addition to providers, I think having those systems in place is also a key component. What about airways managed in critically ill patients? What are some additional considerations that we might have in managing the airway of someone who's critically ill? And anyone can answer this question from our expert panelists. We know how to manage airways in patients that we have time, such as in the operating theater, but if someone's critically ill, what else do we need to consider?
Maybe I can take the question.
Thank you.
So if a patient is critical and you have to manage, first you have to identify who you need to manage the airway with. So if they are like in coma, if they're having severe hypoxemia, like they are having impaired respiratory failure and so, you will need to manage their airway. And one thing you have to take caution with is not to kill them. I was told when I was learning, like once you want to intubate, for instance, someone who is critically ill, be sure that whatever you do might kill him. So you will have to optimize everything else around you. Don't be don't run into intubating them, putting the laryngoscope. You have to optimize their circulation, like make sure the blood pressure is okay. Make sure that they are pre-oxygenated adequately before you go on with your laryngoscope to intubate them, because once they are critical, every drug you give, everything you do can kill them. So that's the best way I can go with that.
Yeah, that sounds very scary, but I think your point is great in that everything that we do has consequences. So you need to be adequately prepared to intubate if that's needed, but we don't always have to intubate either. Dr. Mame, I can tell you have a point about this, and you're an excellent airway expert. So please share with us your experiences.
Yes, I couldn't agree with Lisa more that in critically ill patients, the patient is at very serious risk of dying during your intubation attempt if you think intubation is needed. And as you just said, I think any way to avoid intubation should be considered, as well as just emergent and immediate interventions that you know might change the situation. Like if you examine the patient and they're grossly edematous and you think they're fluid overloaded, and a bolus of diuretics or some nitroglycerin to immediately vasodilate them might change their respiratory situation in a few minutes, literally. So there are some things like, or giving bronchodilators to someone who's having an asthma attack. I mean, there are things that have immediate effect in minutes. And you need to run the list of things that might be appropriate, and then you may not have to manage their airway. I also find that intubating the patient in the safest way possible is a particular interest of mine. And I have done 21 awake fiber optic intubations on critically ill patients in whom I was thinking just that I thought if I induced general anesthesia to intubate, I might kill them. And that was the reason for the awake intubation, not because the airway was difficult. And there has been a recent study published showing that if a patient who's critically ill gets intubated and arrests during your intubation, even though you were successful with the intubation, they have a 50% chance of not being resuscitatable. So, sometimes people think, well, I'll just have a syringe of epinephrine and phenylephrine and other drugs to resuscitate if they get hypotensive. But, if they arrest on you, they're likely to die and not be able to, you may not be able to bring them back.
Yeah, I think there's a great point in the chat box too from Daniel that it depends on the patient's GCS. So for example, if a patient does need intubation, but their GCS is very, very low, you may need less or no medications at all to induce that patient prior to intubation. So I think that's another really valid point. So thank you for that, Daniel. Let's move on since we're running out of time. So I'm going to push this forward. How do you address multiple emergencies? So oftentimes, multiple emergencies happen at the same time. There may be one provider for multiple locations. This can be a very difficult situation. And so, when I think about multiple emergencies happening at the same time, I really rely on a team of providers and an adequate system within the hospital that has a backup plan so that if I'm busy in one emergency, there's a backup person or plan for an additional emergency. How do some of the rest of you manage when you have more than one emergency happening at the same time? How about you, Dr. Lee?
Yeah, so first you have to know your team. You have to know your team and also do the triage, because when you're having a lot of emergencies happening at the time, you have to picture in your mind, what am I likely, or who am I likely to serve, or where will I be more helpful? And then you, depending on your priorities, you go on the person you are likely to serve, but also by knowing your team, you can direct tasks to other people. So while you are doing something life-saving that no one else can do, you can touch someone else to do something else to save your colleague.
Exactly. I also am just going to click on that resource because we've covered these in other sessions, but we do like to use cognitive aids. Because when we're in emergent situations, we oftentimes are nervous and stressed, even as providers, and we may not remember every step that needs to be done. So we've talked about these in previous sessions, but the vast majority of us do not implement all known best practices optimally when we are stressed. So we have links to several cognitive aids. There's an emergency manual here, and there's also another one for obstetrics. So having training and resources, having cognitive aids, and then having protocols and guidelines, as well as the hospital systems in place and good teams built to help manage multiple emergencies. If you're practicing in a setting where it's just you and you can't manage multiple emergencies at the same time, that's really a systems problem. So you need to be an advocate within your own healthcare system to realize that patients are not receiving optimal care because there's more resources needed, and that could be human resources or otherwise. I'm gonna move forward and skip the monitoring of quality of critical care and the indicators simply because we're running short on time. But I wanted to point out again, we had one of the last sessions we did was essential emergency and critical care. And speaking of systems and managing multiple emergencies, you really can advocate for yourself and your teams when you recognize the ideal or best practice scenarios and you compare them to what your reality is in your healthcare system. So all of us as healthcare providers are also advocates. We have to advocate for ourselves and our teams and our resources because that's what we need to take the best care of patients. We always have our patients in mind. But if you look at reality versus best practice, you can oftentimes identify the gaps or things that are needed, and that will help you come up with action plans and identified goals. So that's how you approach problems a lot of times, and how you approach the ideal situation versus the one that's occurring currently. This next question is another big question that could also be an entire session in and of itself, which is how do you manage sedation and choose medications for patients who require prolonged sedation for more than 7 days? This is not only a very broad question, but also one that has a lot of debate around it. So what I have chosen to do is share with you a guideline. This comes from the Society of Critical Care Medicine, and it's a guideline for the prevention, management of pain, agitation, sedation, delirium, immobility, and sleep disruption in adult patients in the ICU. The question from this learner said, if a patient is sedated for more than 7 days. And I'm not going to go through the entire guideline, but it's there for you to go through as a provider. But I think the important point to make is actually in the title, that we're not treating just one thing called sedation. We're actually treating several different things, and that is pain, sedation, delirium, and oftentimes sleep disturbances. So those are separate entities that all come together in these critically ill ICU patients, especially intubated patients. And their problems not only in the acute setting of the ICU, but they also lead to long-term disability in critically ill patients. So it's important for us to manage sedation well. I think much like some of our other questions, the best thing to use is what is available to you. And again, we have to advocate for the ideal situation. So if you don't have appropriate sedative medications, then that's another thing to consider advocating for and within your own healthcare system. So from critical care, we also have some really great resources to share with you. This article talks about the critical care continuum and how critical care can be delivered both inside an ICU, but also in the field, in the emergency department, in the wards. There's a great conversation happening across the globe about improving critical care capacity in all healthcare settings, recognizing that the COVID-19 pandemic has really highlighted the deficit of critical care resources in most healthcare settings. So there's a group of people that are really advocating for the advancement of critical care through education, through systems, through physical resources as well. So reading these two articles, the global need for essential emergency and critical care, and then the EECC or essential emergency and critical care article is a global consensus from ICU practitioners from across the globe. We had also talked previously about using clinical scoring systems. How do you know if your patient needs to come to the ICU? How do you know that they need to be intubated? How do you know they're getting better or worse, et cetera? So here's some quick scoring systems for that. We talk about rapid response teams if you want to know more about that. And then here's some links to the emergency manual, the obstetrics manual, and the Society of Critical Care Medicine sedation guideline. COVID-19 has just continued to persist and really challenge all of us across the globe in how to best prepare our hospital systems to create settings of care for all of our patients. And this pandemic is really lasting a lot longer than many of us anticipated. And we're also learning a lot as we go. So I think over the last year and a half, our care has improved, but we still have a long way to go to optimizing patient outcomes. The first question related to COVID-19 is, how are severely hypoxemic COVID-19 patients treated? And so we can give just a few minutes for people to answer in the chat box, but how are COVID-19 patients treated when they're severely hypoxemic? Oxygen. Thank you, Sabine. Definitely oxygen. Yeah. Yeah, oxygen. And it's just I don't know if the other panelists have anything else to add, but I would just say, in addition to all the things that we talked about in oxygen therapy, COVID-19 patients, there are some very specific therapeutics that we now know are helpful. So depending on the severity of hypoxemia, using steroids has been shown to improve outcomes. Tocilizumab is another one that some people are using. I think the important thing, and something that's been alluded to within the chat box, is also recognizing that providers need to be in personal protective equipment, or PPE. And I would just like to point out that that is not only for COVID-19, but anytime you have suspicion of a contagious infection. There's a lot of discussion about PPE and aerosol generation from certain oxygen delivery devices, such as high flow devices, nasal devices versus CPAP, BiPAP versus whatever. But even a patient talking, coughing, singing, laughing, those are also aerosol generating events. So there really should be no compromising the safety of providers, and everyone should be in PPE. Do any of the other panelists have opinions about?
And I would like to add of all the issues you have commented, that it's important to observe and monitoring the function of other organs different to lungs, as COVID may damage multiple organs, and especially kidney, and all, many like cardiac and brain. And this is important because many people focus only on the other points are very important in this. This is a critical patient, and this must be treated multidisciplinarily.
Could not agree more. Thank you for pointing that out. So all providers caring for patients with COVID-19 or patients under investigation must use personal protective, and that's for contact, droplet, and airborne precautions. COVID-19 is defined in categories as asymptomatic, mild, moderate, severe, and critical, and treatments vary depending on severity and resources available. And you can see there's an active link here where you can read about the different categories of COVID-19. How many liters of oxygen are needed for COVID-19 patients, Dr. Santiago?
Well, I think that, as we discussed before, we need to assess the degree of the hypoxia, and we're going to titrate up and down depending on the oxygen saturation in the patient. But current guidelines recommend to use initially the nasal cannula, and they also recommend to, after escalating to the face mask, before thinking in non-invasive ventilation, to actually go through the high flow nasal cannula. That's the current recommendation.
Yeah, definitely depends on the severity of the patient. And again, we talked earlier about hypoxemia versus need for ventilation and or assistance with work of breathing. So it definitely depends on which device is most appropriate for that patient. Do any of the panelists have experience working with Venturi masks? And how would you use this Venturi mask? Anyone?
Yes,
we use a Venturi.
Yeah.
Go ahead. Go ahead.
I was going to say, we use Venturi masks a lot where I trained. And one thing that's really nice about them is you have a little bit better understanding of what you're actually delivering from an oxygen standpoint. So as an intensivist for myself, when I'm trying to evaluate whether or not someone needs higher levels of oxygen and come to the ICU, if the patient's just on a non-rebreather mask, I don't have a great understanding of what their true need is, since it is such a high flow of oxygen delivery, and theoretically FiO2s are in the upwards of 80–90%. And so being able to titrate allows us to keep patients and think about oxygen again like a medicine, where we want to kind of deliver them in that therapeutic window. So in those oxygen saturations we talked about earlier, 90 to 95%, the Venturi allows you to kind of hit that optimal window without over-oxygenating the patient and without under, which I kind of like because it helps me assess their trajectory, if they're getting worse, better, and where they're headed.
Thank you, Dr. Shannon. Yeah, so each one of these color-coded valves allows a certain FiO2 to be delivered because it allows entrainment of more or less room air. So it dilutes the oxygen. I think it's important. This is a nice table. And again, it's a clickable link if you want to go through it, but to point out that Venturi masks are not superior or inferior to any of the other oxygen delivery devices, but they may be what's available. And earlier in the discussion, we mentioned that we want to use what's available to us and most appropriate of the available resources. So similar to the nasal cannula or a simple face mask, if a Venturi is available, that can be used. Again, it's not better or worse, but each one of these colored valves allow for a different flow and therefore different FiO2 to be delivered. So you know approximately with more information what FiO2 you're able to deliver depending on the color valve that you insert there. We don't use them very commonly where I work, but they are definitely available in many places. Dr. Dati, do you ever use Venturi masks in your practice? And what has been your experience?
Yes, thank you, Anna. We do. Actually, the first time when you asked me, I thought we didn't have, and I found out we have about 3 sets in the ICU.
Okay.
I think they are very, very useful in low resource settings. When you get one, you should keep it with you. There are a couple of advantages here. One, it helps you not to waste your oxygen, and it also helps you to do the right thing or give the right thing at the right time and get the results. With all this, the good thing about it is that if you read on the devices, all this on the chart is written there, how much you can get and so on. So it's easy to use. So whenever we wean the patient off the ventilator, I think our ICU nurses, they use this a lot, and they're very, very much at home with this device. So it is very good.
One other point about Venturi devices that we are not thinking about readily because everyone is very concerned about hypoxemia with COVID-19 and other pure hypoxemia pathophysiology states. But one benefit of a Venturi device is when you're actually trying to deliver oxygen to a patient with COPD and hypoxemia, because in those patients, as you know, we don't want to deliver too much oxygen because we may actually make them worse. And so if you want to deliver a certain amount of oxygen to a COPD patient without delivering too much, the Venturi device is also an option. How is CPAP or BiPAP used in the management of COVID-19? Anyone? Are we using CPAP and BiPAP in the management of COVID-19?
We have used it, Anna, in many instances because there are no ventilators for patients. Those devices, BiPAP and CPAP, are used normally for patients with OSA and other conditions, apnea. But when we have used with patients, we implant the care for as a patient with non-invasive ventilation, taking a point out that the possibility or risk of aspersion of micro tears and aerosols. Those are the care we have used in those patients with these devices.
Yeah, we have used them to some degree as well, where I practice. And there are considerations with non-invasive positive pressure devices with COVID and without COVID. And I think the contraindications are the same. And I think that their use has a place, but it is somewhat controversial for a couple reasons. But it's definitely something that you can consider. So the best treatment for hypoxemia is the appropriate flow of oxygen therapy. Regardless of the device selected, you need to just give the appropriate flow of oxygen with whatever device is available. The use of non-invasive positive pressure, such as CPAP or BiPAP, can be considered, but is controversial and should be considered carefully in each patient, as there are risks to both patients and providers with its use. If you want to read more about that, there is a link. There's also nice non-invasive ventilation as it pertains to COVID-19. There's a video that you can look at for more information. What are the adverse effects of positive pressure in COVID-19 patients? And I would argue this is for all patients on positive pressure, but what are some of the negative or adverse effects of positive pressure? And
well, the potential risk of trauma should always be considered, right?
Say it again, Dr. Santiago.
Yes, no, I was saying that the potential risk of barotrauma should always be considered.
Sure. And so tell me about barotrauma. What is barotrauma?
Right. Well, so we need that in conditions where we need to provide mechanical ventilation. Usually the lung is sick and there is inflammation that makes the lung prone to suffer, as we can see here in the picture, a tear in the alveoli. So basically we're going to have a leak of oxygen and air outside of the alveoli. And this has to do with an increase in the pressure inside the alveoli that is going to basically break the wall and make this leak.
Yeah, so baro suggests pressure, so too high of pressure can actually overstretch the alveolus here. There's another phenomenon called atelectrauma, and that's from atelectasis, or opening and closing of alveoli, that causes a shear force on the alveolus, which can also cause damage. And then we talked about hyperoxia and how that can also have direct cellular damage. All of these things can happen, and this is all examples of different types of ventilator-associated lung injury. And you can see there's lots of inflammatory alterations that can occur and lead to further lung damage. So again, another nice resource where you can read more about that. This was a great question that came in. I thought, since this means that the participant had actually gone to our EECC lecture, and essential emergency and critical care, how do they relate to COVID-19, and are there any updates? This is an evolving discussion around what essential emergency and critical care is. And so this article does a really great job about talking, and this was just published May 24th, but this is the group that is largely responsible for EECC. And they're talking about a lot of the problems that are happening with COVID is we're recognizing that there's an oxygen crisis. And so a lot of people are advocating for additional oxygen. A lot of people are advocating for vaccine access. But what we really need is critical care capacity. And so when a patient has symptomatic COVID-19, the patient's airway, breathing, and circulation may be compromised. We need systems where we can identify early the problem and that care can be given in a timely fashion. So simple equipment such as pulse oximeters, consumables, drugs, staffing, and routines or systems for early identification and timely critical care are often missing, and guidelines may be too specialized or not context appropriate. So the updates is that there are lots of folks working on expanding critical care capacity across the globe. It is recognized. There are very specific hospital readiness and clinical processes that need to be in place for all of critical care, but especially for COVID-19, the big one being infection prevention and control, as well as access to PPE for all healthcare providers. So those are the big updates in EECC, but just so our learners know, there are lots of us working on expanding critical care capacity every single day at higher levels with the World Health Organization and WFSA, et cetera. Our favorite resources, again, especially with COVID, it's covidprotocols.org and opencriticalcare.org. Lots of great information. I encourage every single participant to go through that, and panelists if you haven't seen those yet. The next section is Dr. Datti's wheelhouse here in obstetrics. So how does the approach for oxygen and critical care differ for pregnant women, Dr. Datti? Putting you on the spot here.
Yeah, thank you very much. First of all, we have to be aware of the physiological changes. Then you will now have, when they, like in our settings here, you have, when you have high-risk gestation, there may be need to give oxygen, and you find that you have to manage them in the ICU as well. I'll give you an example. 2 days ago, when I was in emergency, the registrar called me. He had to undertake 2 cases, severe preeclampsia, and then also hemorrhage, antepartum hemorrhage, where you have to give oxygen. So you find yourself in a situation where you will need to give this oxygen therapy. So I think in pregnant women, you also have the target saturation differs slightly from the normal, from the non-pregnant patient. It's slightly lower. If you say if you target 92 to 94%, that is okay. You don't have to target 94 and above. So you don't want to give too much oxygen. So, depending on the setting, like in low resource settings, like in sub-Saharan Africa, we all know where in low resource settings they come in late. You have antepartum hemorrhage. You need to address the hypovolemia alongside you're giving oxygen. You stabilize them, and then they go for emergency C-section. Or laparotomy or hysterectomy. So that is the approach. But in my setting here, the teaching hospital, it behaves slightly differently from what obtains outside these settings. We hardly see those patients coming with hemorrhage and so on. So what we see quite often is those with comorbidities or severe preeclampsia. You have hypertensive heart disease. We also have some coming with some valvular disease, who have had valvular replacement coming for C-section, elective C-section. So those are the things that we see.
Would you agree, Dr. Datti, just to take a step back, that even a normal pregnancy without preeclampsia, without the risk of hemorrhage, that the approach may differ slightly also in the fact that you have now 2 patients. You have the pregnant mother as well as the fetus. And so one thing I think some people may not remember is that we need to monitor both patients, and that fetal monitoring is something else to consider.
Yes, the basic things will apply. First of all, you need to position this patient properly. Left lateral position to improve circulation to the fetus. And then also use sonicare to monitor the fetal well-being. And then you're giving oxygen. So you transport that patient in that position as much as possible. So, and we know that if general anesthesia is indicated, you know that pre-oxygenation is mandatory, knowing that the functional residual capacity is much reduced because of the pregnancy. So those are important considerations when you are treating the pregnant woman, whether they are normal pregnancy or not.
Great, thank you. And I just want to remind the learners that 2 sessions ago, so part 10, we actually went through all of the obstetrics considerations for oxygen and critical care. So a lot of good resources there. I'm gonna move more quickly because we're actually out of time, but is there any benefit to the fetus when you administer oxygen to a woman in labor? The short answer is yes. If the mother is hypoxic, giving oxygen will improve the oxygen of the mother's blood, which then goes to the placenta and to the fetus. So definitely if a woman is hypoxemic, you need to give her oxygen. So oxygen should be given to pregnant women with hypoxia, not necessarily to all pregnant women. Maternal blood supplies the placenta and the fetus and should have a normal oxygen saturation level. According to several resources, several professional societies, they recommend a target SpO2 for pregnant women of 92 to 95%. Note that there's no benefit to 100%. However, the Society for Maternal and Fetal Medicine recommends 95%. So there is a little bit of debate on the exact number, which we're used to seeing. There's never exactly one number that's perfect for everyone, but the oxygen targets are a little bit higher. Are there COVID-19 protocols for pregnant women? Absolutely. Again, we're going to go back to our covidprotocols.org and recognize here there's an entire section on obstetrics. So you can read more about how to manage women that are pregnant and may have COVID-19. So some of our favorite resources, again, we have the link to the emergency manual for obstetrics. There's some great learnings from the Society of Critical Care Medicine about physiologic changes during pregnancy, the Society for Maternal Fetal Medicine. There's a great resource from the World Federation of Societies of Anesthesiologists about fetal heart rate monitoring, and another one about maternal resuscitation. So definitely some good resources that we recommend. In pediatrics, of course, yes.
Sorry for the interruption.
Oh, no,
just would like to share my experience because I work in an obstetric hospital and I see many patients being, forgotten and being focused on the circulation parts. Most of them, especially the high risk mothers, come with APH or PPH or hypertensiveness of the pregnancy, severe preeclampsia, eclampsia, and so on. And most of these patients, when they arrive, most healthcare workers focus on administration of blood products, and IV fluids. But most importantly, oxygen is also a therapy to consider in these patients, especially for the fetus, as mentioned earlier. So let's not just forget that as well. Thank you.
Perfect. Thank you for that stress. Yeah, thank you for stressing that really important point. So those fetuses become pediatric patients to us. So how is oxygen therapy provided for infants and children? And I want to point out a really amazing resource. I've read it 2 or 3 times now while doing the course, but this came out from the World Health Organization a few years back, and it's excellent. This is a PDF you can download, but it's anything and everything you want to know about oxygen therapy. It talks about nasal prongs, nasopharyngeal catheters, bubble CPAP, how to set it up, when humidification is needed, what SpO2 targets, etc. And again, are there COVID-19 protocols for pediatrics? And the answer is, of course, yes. covidprotocols.org, another amazing resource with a large chapter on pediatrics. So there are definitely protocols. The good thing and why we keep stressing and recommending covidprotocols.org is as you go through these chapters and sections, you can actually see all of the literature and articles and data and evidence that has been cited. So you can actually go back to the original article or study and really interpret that for yourself, but you can see how their guidelines and recommendations are actually coming from the literature. So that's why we like this resource so much. So our favorite resources for pediatrics, that oxygen therapy for children PDF from the WHO is just absolutely fantastic. There's another one about critical SARS-CoV-2 in children from the World Federation of Societies of Anesthesiologists. And then we have a guideline for COVID-19 in pediatric ICU for limited resource settings. And so that comes from a really nice article in Nature. So with that, we'll leave you with our traditional inspirational quote that education is the most powerful weapon which you can use to change the world. I'm a little excited and a little sad that this is our very last session. I want to thank Assist International and Project ECHO for all of their support this past year. I want to thank all of our amazing panelists, both this time and throughout the entire year. It's been absolutely fantastic. It's been a true honor and a privilege for me to be able to reach out to all of you and offer whatever support I can through this pandemic. It's been a challenge for all of us, regardless of where we live and work. So thank you so much. And with that, I will turn it back over to Assist International. Thank you so much.
Anna, you are a worldwide leader. Thanks so much for your support and great effort. Thank you so much.
Thank you, Freddie. Thanks.
Thank you, Anna. What a fantastic session and a great way to wrap up the series. As always, we are so grateful to everyone that called in to contribute to today's discussion. We know that many of you are on the front lines of this pandemic caring for COVID-19 patients. And so we hope that all of you have been able to find the content of these sessions valuable and applicable to your clinical practice. I would also like to echo Dr. Freddie and extend sincere thanks to all of our panelists for their time and expertise, with extra special thanks to Dr. Anna Maria Crawford, who has spearheaded this program and created all of the curricula and modules presented over the last 12 months. Dr. Anna, we are so grateful for your expertise and dedication to medical education. We are also grateful to Project ECHO and our partners at ECHO India for making this programming possible, and for our interpreters who have helped make this program accessible to a broader network of learners. Now, if you are interested in continued opportunities to stay engaged in the material, we have launched a number of new learning hubs that are led by clinical directors from a variety of African and Latin American countries. Like this series, these hubs meet once a month to discuss topics related to oxygen and critical care in the context of COVID-19 using a case-based teaching format. The link to register for these hubs will be shared in the chat. The Learning Resource Center is also a fantastic resource to check out for ongoing support. As many of you know, this course platform is free, easy to use, and accessible by both computer and phone. It contains all of the teaching materials presented, along with supplementary resources, videos, job aids, decision tools, quizzes, and more. Our team has also been preparing an offline version of the LRC, and this course book will be emailed to participants in the coming days. Additionally, if you aren't already, you are welcome to join our WhatsApp community group. This is a space to ask questions about the material taught during these sessions and to solicit advice or support if you come across any challenges in your clinical context. And finally, to receive a certificate of attendance for today's session, please follow the links in the chat. And that's it. So thank you so much for your participation, and please do keep in touch.